They're listening in.
Jordan Brunswick, everybody.
I'm not sure. I know Frankfurt is the top right.
Frankfurt's one, ZK the other one.
I'm not sure.
Frankfurt.
Both are Frankfurt.
Independent
Both from
first.
Frankfurt.
Just posting up in separate rooms. Okay. Well, guys, thanks for coming this morning. Like I said, I'm one of the PGY2s, soon to be PGY3s, and just going to talk about water-related, not so much injuries, sort of just conditions, submersion, diving, so forth. So start off with diving. Initially, we'll touch on hypothermia as a word, and then we'll talk about drowning. Just kind of touch on these things. I left a lot of the extrication part out of it. It's certainly a little bit more on. You all know that pretty well. Some of you are scuba certified, and that's a little bit more in your wheelhouse than mine. But to talk about the medicine behind it, that's really what we're here to touch on too. Not the kind of diving I was talking about, but obviously still pertinent given our patient population. This is the kind of diving that I was going to talk about today. Plus or minus the fire extinguisher. So your boring science lesson 101, today is Thursday, and I took high school physics, but I hated every moment of it. Boyle's Law on the top. The reason why they're pertinent is I'll talk about in just a little bit. The pressure and the volume at one setting, pressure times volume is equal to a certain quantity, is equal to the pressure times the volume in a different setting. So they're equal to each other. So if you change one variable, you have to change the other variable. That's Boyle's Law. Dalton's Law, and obviously started by a different dude, basically says the total pressure is the sum of the partial pressures. So the total is the sum of the parts. Makes logical sense. And Henry's law, being the quantity of gas in a solution, is related to the partial pressures of the two. So who gives a flying flip, right? Other than boring science lesson, I just need something to fill my slides with. This is why it mattars, because barotrauma is directly related to everything with regards to Boyle's Law, and I'll touch on that as we go. Dalton's and Henry's law are the scientific principles behind decompression signals, behind all those things. So certainly, does it matter to your practice acutely? No, you're not going to be quoting Dalton's law to each other, but it's very, very helpful to understand why things happen the way that they do, so you can further understand how to take care of these patients the best way possible. So into the depths we go. Personally, my least favorite anatomy lesson of medical school and everything going through, hated the inner ear. Absolutely hate it. But with regards to this, as you're descending, as divers are descending, there are a certain amount of conditions that they certainly stress or certainly worry about or are at significant risk to getting. One is barotitis, so barotrauma to the inner middle ear. If y'all are familiar with the inner ear anatomy, so you have the tympanic membrane, and then your malleus and stapes, which are going to touch onto your cochlea and your vestibular canals. Barotitis has a little bit to do with, if you can imagine, Boyle's Law. As you're descending, if your eustachian tube becomes blocked, the pressure increases. So let's say your pressure doubles, the volume of air in your middle ear is going to half, which is going to cause inward bowing and damage to your tympanic membrane, potentially some balance abnormalities, just a significant amount of hearing loss. And if you're unable to clear that, you'll just continue that damage to worse. So whenever these people surface, they might complain of significant pain to one ear. They might have a little hemotympanum or so forth, maybe even a little nose bleeding, want things to act back up. Sinus barotrauma, along the same sort of principles. If the osteo or the openings to your sinus and your nose are occluded, they've got viral respiratory disease, something like that. The amount of air in that enclosed space, because the pressure increases, basically just sucks the lining of the sinuses down, rips them straight off the bone, and then once they come back up, you're just getting like profuse mid-face pain, profuse nose bleeding, that sort of thing. Inner ear barotrauma, sort of the same thing. Whenever they are descending, if they kind of cough against a closed glottis or try to valsalva, they get damage to the oval window and the round window, which are kind of like the dampening systems. Look at it about here and here, which are kind of the dampening systems between the vestibular system, the semicircular canals, and the sound system. So they're basically just going to get significant symptoms related to that. What does that mean for us? Even for me, certainly for you all, supportive care. That's essentially all we're going to be able to offer these people, and all I'm going to be able to offer them for the most part in the ED. So just get them to us, help control their pain, help control their symptoms, their anxiety, so forth. Other symptoms associated with descending to you. So something called mask squeeze. Actually, if you descend too much and you don't equilibrate the air between your mask and your face, basically going to suck your face right into the mask. Basically just look like you've got all this busted capillaries and so forth, just like you see here. Something called tooth squeeze, actually. So if you get fillings, I just recently got a couple of fillings. If there's any air inside, as the pressure decreases, you're just going to crush those teeth. So all that stuff certainly happens if you don't take the proper decompression stops. And something called skin squeeze as well. Air pockets in the suit, basically going to pinch it off. Anyone have an older brother who gave him that Indian rubbering thing? No? Yes? Yeah, I hated that stuff. But same sort of principle here. So we're coming back up. Two of the kind of bigger things that we worry about on ascending coming back up. Number one is vertigo. If they're not, like I said, clearing their eustachian tubes, clearing their sinuses, and they don't get those pressures equalized, similar to how a plane takes off. You get that full feeling in your ear. You might feel just a little bit disoriented. You don't get that cleared. They're going to just be a little bit dizzy, vertiginous. Usually that goes away. You usually don't see any life-threatening complications or significant morbidity. More importantly is going to be the barotrauma. So we talked about Boyle's law. If you can imagine adding more, so you increase the pressure, so you have the amount of volume due to the pressure, if that makes sense. Now you're breathing in air from a tank, so you're adding in on top of that. All of a sudden, you rise too quickly, your lungs are hot because you now overfilled the containers. Does that make sense? Mm-hmm. Okay. Make sure I'm not like zoning people out or y'all falling asleep on me already. Totally reasonable. Here's why it matters. And I'm going to talk about this in just a little bit. Puts you at significant risk for gas embolism. Pre-existing respiratory conditions. If these people are dying, dear God, I hope you don't have like COPD people that are dying. Otherwise, they're just going to be set right up for this, and we'll definitely be seeing. But supportive care. Oh yeah, how's that one now? So we'll touch on decompression sickness. There's a couple different types, just to separate it out. The first type being pain only. We're just going to describe kind of a deep pain. It's in maybe joints, hips, shoulders most commonly, and deep in the same sort of pain that most of America felt whenever Donald Trump was elected. It's kind of that same sort of pain.
Easy now.
I said most. I didn't say whether I felt the pain or not. Type 2 being a little bit more of the serious one. This is where you get from just beyond generic pain symptoms, things like that, to where you actually get neurological dysfunction, you get cardiac dysfunction, pulmonary dysfunction. The reason why I separate decompression sickness, it was hard for me to understand the difference between the two, but decompression sickness at its very root is related to those two laws that I talked about, gas coming out of solution and stretching those blood vessels and all that tissue around it, caused by basically damage to all the tissue. It releases inflammatory mediators. So if you can imagine how does sepsis work? It's an over-exaggerated response by your body. It's a similar sort of a thing. So differentiated from the gas embolism, which is actually sort of like a stroke pattern. You get a definite occlusion at a certain spot that's going to cause a certain syndrome. So the strokes, that sort of thing, like we all know and love, maybe. With a gas embolism, usually these people are going to rise. Maybe they'll have some setting of barotrauma and they'll die right once they hit the surface. If they don't, they can be altered. They could have a seizure, some other neurological dysfunction, but it's going to be a little bit more vague than just, I feel a little bit dizzy, like I got some weird tingling in a hand. It's going to be a little bit more definite than that. What do you do for these people? Oxygen, 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 strap on more oxygen. Hopefully not over the stoma. Give them IV fluids and give us a call ahead of time, because we'll call up this gentleman, Charles Eckerline, and we'll get our hyperbaric system on working. Walt, do I need to worry about this thing? Log out.
Sure, it's nothing.
Time to wake up. Probably is nothing. Anyways, so this handsome silver fox here is our resident hyperbarist. but give us a call and these people just need recompression immediately. So we'll touch on hypothermia. A couple different, I'm just going to skim this a little bit. We all learned this, different stages of hypothermia, mild, moderate, how to differentiate the two at what temperatures. A little bit nebulous, there's a little bit of overlap, but matters more just for prognostication and the pathophysiology behind it. So the ways that you lose heat, back to basic science 101, evaporation, the things that really matter for us, conduction, convection, and you're going to have a little bit. So not a whole lot to be said about radiation as far as contributing to heat loss, but these are all ways that heat is lost. So as you're treating these people, try to remember how they're losing the heat. Pathophysiologically, what's going on behind it is people will get initially hypertensive and tachycardic as a sympathetic response, but then parasympathetics will start to take over. They'll get bradycardic, become hypotensive, and their bodies will essentially kind of shut down from there. They'll go into shock, renal failure, all those sorts of things. Everyone's favorite issue, EKG changes. Initially, they'll start with bradycardia with just a prolonged PR. They'll go into some QRS widening, have a prolonged QTC, and you may or may not get lucky and see the J wave. Now, does this matter for us? Not especially. It's not pathognomonic. It's something like if you print it out, sweet, keep it for training, but don't call ahead, be like, this mother trucker's got a J wave, guys. You need to do something about this because we're kind of gonna, all right, get them here. And as you can see, there are several other causes for this. Most common in the precordial leads. Biggest thing as well with this is not to mistake it for a STEMI. This, with the morphology that I have listed here, it's easy not to, but there are a lot of examples out there if you Google it, if anyone's a laptop, where it actually looks like a more slow upsloping. Researching into this, I came on the time-old question was, did Rose actually kill Jack in the Titanic? Everyone seen the movie?
Yeah.
This one bothered me for a little while. And I found out that sure enough, they both could have fit on the door. Really frustrating. She totally just killed that guy. Like true love, right? So looking through our protocols. These are on the Kentucky website. These are as of December 2016, rather, the updated things. With regards to hypothermic patients, just to point out a couple things, y'all can read these on your own, but the second bullet off the top, careful handling. I'll talk a little bit about rescue collapse here very shortly, but these people are potentially hemodynamically unstable, meaning if your cot falls over, heaven forbid your cot should fall over, but if you extricate them and they're bumping, jostling around, they could go into a dysrhythmia and potentially crash from that. Active rewarming, get the wet clothes off, warm them up, keep your rigs warm. Hopefully y'all have warmed IV fluids with the capability to do so. Run that stuff through. Most of these people, they're kind of two trains of thought on whether or not to warm them up quickly or warm them up slowly. Most of the people go into a slower stage of hypothermia. That's why you'll see some of the better outcomes neurologically. But the current thought is that you should still warm them up as quickly as possible. The medic orders, sort of the same thing, just to point out that the protocols would say defibrillate once if they're in a shockable rhythm, but then just continue with their resuscitation. Don't keep shocking if you think they are. Just get them extricated, and then if their core temperature is up, you're able to get that up, then you can continue shocking. But if they're under 30, just shock once. Moderate hypothermia, same sort of a thing. The biggest reason why I included this one up is this middle bullet point, just to make the point that when you're hypothermic, your whole body metabolism slows down. Right. Makes perfect sense. So the drugs that you give are not going to be as effective like you think they're going to be effective, much like in a code where it takes 5 cycles of CPR to get that 1 milligram of epi rolling through the system. It's going to be the same sort of a thing. So especially if you have to RSI, if you don't have RSI capability, your doses of etomidate might not be adequate. Heaven forbid you should need etomidate. And severe, basically just going to be called medical control. I'll talk to you right now about declaration of death. As with anything that we do, you also field termination guides. If there are obvious signs of death, no head, no arms, chest is hanging wide open, you got a stalagmite through the chest, you know, something crazy like that, you can field terminate. If there are not, you go down to the next arrow and then consider other causes. So did this guy have an MI, fall off the deck while he was ice fishing into the water, and then we just recovered him, you know, an hour or two later, that sort of thing. But he had a known precipitating event that then caused the hypothermia versus becoming hypothermic and then having cardiac arrest. And any special circumstances, much like we'll talk about. The whole point why I bring this up, is to emphasize the ECMO part. Special considerations. Kids tend to have a lot of surface area relative to their 20 to 30 pound body mass, so to speak. So these kids are going to get cool quickly, but they're also going to be able to reverse that. They have a higher tolerance than you or I, or certainly Walt. Olympic is more in the kid range back there. But the kids will actually tend to do better than we will because of this. ECMO has been shown, I put stave, not stage. So ECMO has been shown to have great outcomes in stage 4 and even some stage 3 hypothermic patients. This is really where it's heading in the future. Is if we're able to get these people stabilized to us soon enough, get them on ECMO. I know we have the transport team, certainly capabilities are increasing. Then that's going to allow the rest of their bodily functions to increase while we kind of manage the rest of that. I touched on it a little bit, submersion versus immersion. Submersion head first versus immersion body first. Immersion, immersed tend to have better outcomes because they're treading water, heads above water, they're still able to breathe, and their bodies are equilibrating with the temperature itself before they go into cardiac arrest. Submerged patients, head down, plus or minus a C-spine injury, but they go into shock, they go into cardiac arrest because of that, and then they become hypothermic. These are the guys that don't do well. If you have the chance to equilibrate with it, then you're going to have better outcomes. Finally, talk about drowning. We're drowning today. I'm not sure how exactly accurate these stats are, but it came straight from Titanolis. Plus or minus about 1 million drowning events, quote unquote, with maybe just over 1,000 to 2,000 deaths. In the 1970s here in Kentucky, that was about 8,000 deaths. Or not Kentucky, nationwide, 8,000 deaths. So anyone go down to Cumberland and see their board where they mark how many drowning deaths have happened over the year? I always track that when we're down there boating, just to remind myself not to drink or anything. 3 age ranges that you're going to see this in. Kids, obviously, babies in the bathwater, kids that are just falling in, can't get, or playing around with having for a 5-gallon bucket, they go head first, they can't get themselves out, or something like that. Teenagers, obvious reasons, experimenting with alcohol, they're going skinny dipping, trying to impress some chicks. That's when those things are going to happen. In the elderly, they fall in the bathtub, break a hip, they can't get out. Those sorts of pictures. Those are the typical age ranges you're going to see it. With regards to drowning, we thought once upon a time that the diving reflex was going to be protective of it, but what we found is that it actually doesn't affect anything beyond 6 months of age. It's very prevalent in the first 6 months of life. After that, it doesn't really have an effect. And all it is once your body enters the water, you start to have that physiology that we talked about. You start to get bradycardic, you start to get central shunting, peripheral vasoconstriction. Everything goes to the heart to supply the heart and CNS system. But what we found physiologically is that when you throw an adult into the water, except me, I tend to get pretty anxious about it. So I'm starting to get that fight or flight thing a little bit, which completely blunts any of this. The rescue collapse that I talked about a little bit ago, when these people are drowning, when they're at increased risk for this cardiac dysrhythmias, especially the deeper they go, especially once you get under 30 degrees Celsius. So if you jostle them a little bit, I don't know how, certainly how much they can take. I'm sure it's individual between it, but I include it to let you know, to think about when you're going out to these scenes, to talk with each other, plan out how you're going to do this extrication, plan out how you're going to get them transported as safely, as smoothly as possible, That way you're minimizing extra steps, minimizing wait time, and you're able to get them transported to the place where they need to be. Just to touch on the CNS protection part that I mentioned, obviously they're going to have much better outcomes if they're cooled and then they have that final event become hypoxic versus they become hypoxic, arrest, and then become cool. You all have heard about wet and dry drowning. Dry just being the initial laryngospasm that you get because of it. I think some of those terms are coming kind of out of vogue as of late, but for our purposes, definitely still know them. In case you forgot. So what do we do with these people? Time is the biggest factor. What they've started been finding is that there have actually been cases where people will palpate a pulse. This is the one time where you can spend 30 to 60 seconds palpating a pulse. Like, forget the 10 seconds. Take your time. See if you can actually palpate a pulse. And if you feel something a little bit thready, you can actually extricate these people. There have been cases where people have or have not, or intermittently have felt a pulse, extricated for an hour, and then started resuscitation, and these patients have actually done well. So it goes back to that metabolism, decreasing the oxygen requirements of your body. CPR if they need to, ventilatory assistance if they need to, like I said, oxygen, get oxygen to the body, and intubate if they need to. Talked to you already about active rewarming. This is all the same sort of stuff that we're going to do, plus or minus maybe a little fancy stuff that may or may not improve outcomes, like dual exhaust or bladder irrigation, those sort of things we'll throw out. But y'all are really where it starts in the field. Bring them on all of these conditions, absolutely bring them to us. Any sort of altered sensorium, if they can't tell you exactly what happened, or they're not all the way to it, or they stop breathing even for a little bit and you're like, shit. Or if we need to assist in ventilations, respiration, bring them to us. No ifs, ands, or buts about it. Again, our protocols, bring it up just for the purpose of time. There isn't a whole lot to do with regards to an ALS standpoint beyond just the BLS that comes with it, but just to stress the importance of time, extricating these people in a safe, timely fashion to help improve their outcomes. Thank y'all for your time.
Thank